my lecture today is on social emergency medicine and clinical practice. Disclosures, no economic disclosures, but it is a topic that's close to my heart. I've been involved with the mini fellowship thanks to David and Chrissy and the lecture series, and have worked on stuff going back to med school within this realm. So maybe something to disclose in that sense. A bunch of acknowledgements that I really just wanted to call out at the very beginning. David and Chrissy, as I mentioned before, Scott Kendall and James Willis, Smriti, Adrian, who myself, and then with Stephanie Gopal planned the die-in last year with the help of T. Smith and Robert Gore, Paul Heim, who've been doing these things with since med school, and everybody else up here who's, I think, embodied a lot of aspects of this talk, and everybody who spoke this year. Just very quick outline. We're going to introduce the lecture, brief review of social EM, and then a little bit of some maybe scenarios to have us think about how we're going to treat some patients. So the idea of this lecture is a little bit of spaced repetition. A lot of the topics, or probably all of them, were covered in our lecture series this year. And so I just want to kind of finish the year bringing back all those topics, or only a small portion of them actually, and just kind of bringing a little clinical context to them. So I want everybody to come out of this lecture understanding and being able to recite what social EM is. I want you to be able to understand how racial inequities affect outcomes, how you can kind of recite different ways. In this case, it'll be our Port Clinic of ways that you can care for post-incarcerated patients, understand OST-MAT, that's opioid substitution therapy, or medically assisted therapy for opioid use disorders, and kind of always aiming to put your patients and community first. And hopefully everybody at the end will say that they're an advocate for their patients and community. So what is social EM? What are we talking about? You can't have a social EM or a social medicine lecture without talking about Rudolf Virchow. It's not just the triad, and this is probably more what he dedicated the vast majority of his life to. This is somebody kind of just very briefly describing Virchow. Virchow studies in social medicine and infectious diseases called for social change as a solution to medical problems, which I think encompasses everything. And William Osler, I think he was one of the founders or founding physicians at Johns Hopkins, I think speaking, over 100 years ago to medicine at that time is very prescient and similar to today, and saying about the US, in this country, doctors are as a rule bad citizens taking little or no interest in civic, state, or national politics, a supporter of all reasonable measures for the relief of the people, and this is describing Virchow, as a supporter of all reasonable measures for the relief of the people, a strenuous opponent of all class and repressive legislation, and above all, an implacable enemy of absolutism. And he concludes, today he would be called liberal, but then revolutionary. So I think we would say the same thing now. So what is social EM? I think this is directly from ACEP, if I remember where I pulled it from. So social EM is an emerging branch of emergency medicine that explores the interplay of social forces and emergency medicine and how these interact to affect the health of individuals and their communities. Initiatives in social emergency medicine include research, direct service, and advocacy aimed at addressing the social determinants of health. So very broad. So anything you're doing in the ED, whether outside of your shift or in the shift, trying to in some way address something that's more structural in treating the patient, is social emergency medicine. So here's one of the people who kind of inspired me from the very first day of medical school. Maybe you can guess who it is. In their story, 1963, Baltimore, Johns Hopkins University School of Medicine. 12 years after Henrietta Lacks entered through the colored blacks only entrance for cervical cancer, young medical student tries to fight for equality and equity for all people, going to various protests during the 60s. And the dean of the medical school actually gives you an ultimatum to stop protesting or withdraw. So what would everybody in this room do? Would you stay a medical student? Would you keep pursuing your dream, or would you kind of say this is not right, the way that this hospital, which at that time was still segregated, even 12 years after Henrietta Lacks, was pretty much abused by the healthcare system and had her cells stolen and unsuccessfully treated. And Priyanka actually really had a good lecture about some aspects of this, as did Dr. Riggins. So what do you do? Who is this? It's actually Dr. Goldfrank of, Goldfrank's toxicologic emergencies fame. He quit. He left medical school. He went off to Belgium and later decided to pursue medicine again there, returning to New York City, to the Bronx, and being one of the founding fathers of emergency medicine and kind of pursuing a life of social EM. So that's one. All right, how about this one? It's like 1970, South Bronx. Maybe I'll be corrected for the year and exact involvement. Lincoln Hospital, young medical student from Brooklyn was rotating at Lincoln. Group of residents, medicine and peds residents. I think the peds residents are the ones who I've read the most about. Organized with the Young Lords. I think some people would call them a gang now, but back then they were like the Black Panthers and they were advocating for their community. They actually occupied the hospital for with seven demands. And their demands, which I think still strike what we should be thinking about today, is they didn't want any cutbacks for jobs or services in the ED. They were building a new hospital, so they wanted them to actually finish the hospital building, fully staff it. They wanted to create a door-to-door preventative care program emphasizing nutrition, drug addiction, child and senior care. They wanted a minimum wage. These are things we push for still today. Daycare for children of patients, workers, and visitors. I mean, how often are you in peds and you're watching and looking after a child of a patient somewhere else that we don't have these services that back in the 70s people were thinking about? And they wanted a community board to actually run the hospital. They wanted the community to be like directly involved in the hospital's care. So who are we talking about? Dr. G. So another person we should all be thinking about, who probably trained more emergency medicine clinicians than Dr. Goldfrank at this point, because he's worked at two of the biggest residencies and one of the oldest ones in the country as the founding program director, I think, at that time. So somebody I think we all need to be thinking about when, you're taking care of patients. I think of, both of them as being maybe consciouses, sometimes little voices speaking to me when you have something that you need to think about. So some clinical scenarios. Some people might recognize who this is, at least the picture. Dr. G probably does. Yeah, Dr. Lucchese does. So 61-year-old male comes in for a cough for 3 months. No past medical history, at least that's being disclosed. Smoked for 45 years or 45 pack years. Just a little hypertensive, exams normal. Dr. Sinnert's not here. maybe that would have been nice. Okay, so you want to discharge this patient. Like, what do you want to do? This seems like so stupid. They're hypertensive. They're in the main ED. They're not even fast track. Is this patient going? You're going to just discharge them, Jenna?
I mean, I would get a chest X-ray, maybe start him on a Lodocaine, make sure he has follow-up in 1 6 months.
Yeah, I think that's great. And that's probably not what all of us do. A lot of us are, let's try and get them out as quickly as possible and just discharge them. What, Don? EMIM clinic, perfect. Yeah, lung cancer is a huge issue. That's sometimes all that people present with when they have lung cancer, and they can maybe be bounced around all throughout the healthcare system. They might never get a chest X-ray. They might get, just told they have bronchitis because they're coughing for 3 months and be started on cough suppressants. I actually hate giving people cough suppressants. This just shows that there's disparities in certain communities, specifically Black patients compared to white patients, that there's about 77 more deaths per 1,000 Black patients with lung cancer. And when they go through the analysis, it looks like the majority of them is attributed directly to a lack of surgical care. Now, surgery isn't always a cure-all, but it does mean that there's unequal access. And this is actually trying to normalize. And you can look at the curve on the right, and you'll see that even when they do get surgery, their outcomes are still a little bit worse. And some of that's because they don't have as much care. They aren't able to access primary care in the same way. They don't get screening. Now, technically, if you smoke, if you have 45-year pack year, you should probably be getting a screening CT to see if you have lung cancer, especially for somebody who's possibly symptomatic. So what we do in the ED, discovering a lung cancer, which I think we all have at some point, in my 4 years I have, I'm sure, in maybe even 1 year for some of the interns you have as well. And this shows that actually there's at least one study, this one, that shows that if you do a really good educational intervention, you can not only take people's outcomes and make them equivalent to the white baseline average reference group, but you can actually make them have better outcomes, have better access to care, and it also improves outcomes and access to care for white patients as well, not just our underserved population. So it's good for everyone. So this is a heat map of asthma prevalence, and you can see, don't know if the arrow, so we're, right over here or so, pretty bad asthma. When I was a medical student at NYU, they actually got rid of their asthma room. They made it into a recess room. There's like no asthma. I don't think I saw one asthmatic as a med student at NYU. Maybe David or Paul or somebody else has a different memory, but nobody had asthma. When I came to Kings County, every day in the front is asthma. When you're in peds, every day is asthma. And you can even just see it by the quality of the air or the trash depot drop-off that's right next to the hospital, and compare that to the ones on the west side of Manhattan that are now beautiful and meant to keep the area clean. And then if you just click over to, this is the percent of areas that are white. So just to see, so you can see where it's empty over here. Here's Kings County. There's very few people that are white. It's almost an exact inverted map. So this is a huge thing that we face in the ED. If you can do things that prevent people representing for asthma, that can help address asthma in the community that is disproportionately affecting one community, you're making huge differences and you're helping the ED, right? If we prevent asthma in our communities, then we're actually reducing frequent visits to the ED, we're reducing pediatric admissions, we're reducing long-term lung disease, COPD. This is only good to think about our community and not just what comes in and how we can treat asthma itself better. All right, so 8 hallway. We have a 28-year-old guy, history of opioid use disorder, non-insulin dependent diabetes, just coming in for a med refill, finger stick 650, or we actually, I guess, sorry, it should have been greater than 500. This must be a very good glucometer today. So what do you want to do for this patient? Give him a few cups of water, get the finger stick so that you can detect it. You don't think he has, DKA, so you're just like, okay, drink some water. I want you to have a detectable finger stick and, refill his meds for what, 1 month? I think that's what I was told is like a pretty straight rule of thumb as an intern is give people 30 days of meds to refill them. And, if they're not in DK, they can just go home. Any thoughts, anything else you want to ask this patient, why they're, why they don't have their meds, why they're looking for a med refill from the ED instead of calling their primary care doctor? Well, if you talk to this person a little longer, they might tell you, I actually just got released from prison a week ago. They said they were going to hook me up with some primary care and send some prescriptions, but my Medicaid didn't really go through. So I went to the pharmacy. It didn't work. They didn't have any of my meds. It didn't seem like my Medicaid got activated. I saw a few patients like this in Fast Track. And at the end of the day, if he's coming here today because he has nowhere else to go, because the ED is the only place. And I also learned pretty quickly that if I didn't send this person at least 90 days, even if I gave them a follow-up to Kings County, if I guess I wasn't sending them to EMIM Wednesday clinic to be seen right away by Don, they don't ever get to show up. You know, it takes a year for them to get their actual appointment, and they come back with the exact same finger stick and refill complaint, or they just become disillusioned and they stop showing up and they have a really bad outcome. But Kings County, actually, we have a really good resource. It's called the Port Clinic, and it's specifically to help people like him because, and who was it? Miguel had a really great lecture about incarcerated patients and post-incarceration care. And 1 to 2 weeks after discharge or release from prison from incarceration is when tons of people pass away and suffer many ill effects, whether it's opioid overdoses or just a large variety of complications of complex medical diseases that were being treated in prison and now are no longer being treated. So everybody coming out of prison is at really high risk. And that's why Dr. Dreamer, a number of other physicians at Kings County and throughout the entire city operate transitions clinics to actually improve care for patients who are coming out of prison, to give them more directed care. And there's some, ours is called Port, I think Wolfram just asked. And the number is included in Clinical Monster. I think MJ put it on the clinical resources, and then you can click on like incarcerated care to find the flyer for it that you can give to patients. They can call a number. The evidence isn't great because the studies are hard to do, but it seems to show that if you do send people to a transitions clinic, such as Port, from prison, you can reduce ED presentations. They still end up getting hospitalized, though they have shorter courses, but reducing ED presentations, that's great for us. I think it's great for patients too. And in addition to that, something that most transition clinics do, and this person would probably benefit from, as I mentioned, you know, overdose deaths are actually pretty high within 2 weeks after being released from prison. And people who are started on opioid substitution therapy live longer. So if you have a patient who's recently incarcerated, has maybe a history of opioid use disorder, referring them to, whether you induce them if they're in withdrawal with buprenorphine, or refer them to a methadone clinic or to the R building or another resource to get started on opioid substitution therapy, you're saving lives just by addressing something that we normally don't think of as being like the emergency department's required, you know, area of expertise, but it is becoming that. So anybody recognize who this is? Yeah. So River Phoenix, if you know who he was, he died pretty young of opioid overdose, maybe cocaine, but probably was opioids. You have a 22-year-old male, presents just for generalized body aches, diarrhea, nausea, vomiting, tachycardia, hypertensive. He's agitated, he's walking around, and he's just screaming, "Why isn't anyone helping me?" These people are walking around the ED all the time, and a lot of us probably just let them walk out of the ED as they're getting frustrated with not being helped. But if you actually, why did it not go? There, it was just a little delayed. If you actually calculate the COWS, which is the clinical opioid withdrawal scale, you'll see that his is 25, which is through the roof. I think it's a good moment to mention Edwin, who just passed away, who was one of our peer counselors. Our peer counselors are amazing, and Edwin actually, and I've been in the meetings and I've seen it, he was the person who gave, hands down, the most consults, spoke to the most patients, and really did the most. So I think it's a huge loss for our whole department. for his passing. And I think they're planning a funeral right now. But this person, and we had a great grand rounds about opioid use disorders and inducing buprenorphine from the ED from Gail D'Onofrio, the chairman at Yale. This graphic is just to show that people who start opioid substitution therapy live longer. So again, inducing people in the ED, referring people to be started on opioid substitution therapy is real solid, clinically evidence-based medicine to actually extend people's lives. So pushing forward again, making sure that anybody who you think is experiencing opioid use disorder, having the discussion, figuring out where they are in stages of change is really helpful and helps them more than, so many other things that we do or don't do for patients. And this is directly from Dr. D'Onofrio's lecture that again shows that people do better if you give them opioid substitution therapy. I'm purposely trying to drive this home as a point that we should be doing more of this, and that it's really important. I think also in the future, wherever people go, this is going to be in a lot of other hospital systems more and more common and required. And I think a lot of the people in my class who are graduating are going to places that do this already, are being required to be trained. X-waiver is not so required anymore, but you still need to know how to induce people and start people on buprenorphine. And so most hospitals, this is just required. You might not get your bonuses if you don't do this. You might not get a variety of other incentives that you'd be losing out if you don't do this. So it's just something to really think about. Okay, 17 hallway. We've all had so many of these patients, comes in through EMS. If it happens to ever be scanned in, says sleeping in the wrong place, maybe, somewhere where they're not supposed to be. Somebody called EMS. It's never entirely clear to me. It's never often even entirely clear to the patient when you finally do talk to them. And they've refused vitals, finger sticks, and they're just in 17 hallway. And maybe everybody knows them. They've been here frequently for 7 visits in the last week. One thing that I think we don't do a great job at, and this isn't any of our fault, because I remember my first shift working an overnight and thinking that maybe we could have some good housing resources or something. And I put in a social work consult and I was like, okay, this is going to be great. And I got Mr. Ward. And he's like, what do you want me to do? I'm going to refer them to Bellevue. I'm like, you mean the 30th Street Men's Shelter? I can do that. I started a program there as a med student. Like, I can tell them how to get there. I can give them better instructions than you. And he's like, that's all I do. I give them a printout. There's not great, and I tried to go through, there's really not great evidence to support or go against housing first programs. And if you're not familiar, housing first is the idea that you give people housing before they stop using drugs, before they kind of get their whole life together. In the past, to get housing, most programs, most places required you to literally be sober, have a job, get your entire life together. And, housing first models and other special programs are really meant to get people as quickly off the street into the community, into a home, and have like social and support systems. And, sadly, H&H downstate, we don't have the money, but a lot of kind of wealthier hospital systems have seen that, and they do it. And wealthy hospital systems don't do things that don't make them money or save them money. That it seems to probably reduce ER visits, that it, reduces complications because it improves med compliance. And so you don't get patients who show up every day. I remember once talking to Randy and Nympha about the cost of our patients with sickle cell disease that come every single day through EMS. They cost, and I'm sure some of our many former patients at county, people who show up every day, cost more than almost anybody else in the entire Medicaid system because of how they utilize the system. And it probably, in most cases, would be logical and cheaper to actually just give people housing, give people better social support. But it's difficult because of the way our payer systems are set up, that insurance isn't paying for it. It might save the hospital, but you can still bill. So it's complex of where that money, that zero-sum game is. But it's something we should really think about. And how many times do you just walk around and get asked for a sandwich and you're like, I'll try and do it, and you get around to it maybe, or maybe you don't. Maybe there's no sandwiches, patient gets annoyed. Well, one thing that we did this year was start giving food boxes. And so I just wanted to share a few really quick snippets from our little survey that we're doing so that people could log entries. So this is about a patient who had just moved into an apartment across the street. They got sick from dumpster diving because they couldn't afford food. They were asking for extra sandwiches in a Ziploc bag. The person saw him putting it in his bag to take home, and they remembered that Dr. Adrian mentioned we could offer patient boxes of food to take home. He was surprised and happy to receive such a large box. A foster mom who wasn't getting her checks due to an unknown delay was apparently very happy to get a box of food. A patient who is living in a shelter for 6 months after being a victim of domestic violence, has 3 kids who she has to feed and care for at home. Patient's grandmother was recently lost their job as a kiosk attendant at a local college due to COVID, with 2 other younger children in the household, has had difficulty buying food. Somebody who was brought in by EMS, who really at the end of the day, nothing was wrong with them, but they were extremely happy to bring back food. Another victim of domestic violence who hadn't eaten because she had to leave her home after being victimized, and she was incredibly grateful for the food, but she didn't know where she would sleep tonight. And this patient just smiled. So this is, as I said, whenever I see patients like this, I think about Dr. G, I think about Dr. Goldfrank, and sometimes I go a little extra mile for a patient who I know we all kind of ignore a little bit, or are going to be ignored. You know, patient with a history of cocaine use disorder who shows up with chest pain, who every time is always discharged and never gets the workup that somebody who's so high risk would otherwise get, because you speak to medicine, you speak to cards, and all they say is it's his cocaine. Which isn't necessarily a reason why they shouldn't be properly treated and getting the same evidence. I think most of us try and practice this way. Any questions? Comments? Jenna?
Thank you very much, Noah, and thank you for all the work that you do about that. I do have a question. You, in one of the slides that was very beginning, you mentioned something about like educational intervention can really decrease the racial disparity. But what does educational intervention mean?
Oh, if I said education, I mean, I think it's more educational to us to understand that these things exist. Because if you don't accept that there's a problem, then you can't actually address the problem. And so I think we need to accept that there are racial disparities in health outcomes and how, you know, investment and has occurred in different communities, and that we have to invest, you know, disproportionately maybe in communities like ours to actually, you know, make things equitable.
That was a great lecture. One thing I like about you a lot is that you're a football player, because you don't only just talk the talk, but you walk the walk. You've done that for the 4 years you've been here. I think that's great.
Thank you, Dr. G.
Our social workers refer people to NYC Care and then set them up with it.
So, I mean, New York City Care, it's relatively limited still on who, it's just for people who are undocumented, right? Who need.
Now, you're going to change this year, right?
Was it? I thought they just expanded the boroughs that it provided, but I see Taylor Conrad, whose wife, Chelsea, would know better. So maybe.
It's expanding, but it hasn't.
Okay.
So soon.
So then just a quick summary. Social EM is clinical medicine. And I think we have to accept that what you do outside the hospital or what even the small things, whether it's feeding a patient, does improve clinical outcomes. It's not perfect. A lot of research is imperfect. I'm going into tox. Tox has very imperfect research as well. But if you do see a patient, try and screen them for opioid use disorder, because that is one of the really most evidence-based areas. Try and screen people for incarceration, and you can refer them to the port clinic. If somebody has food insecurity, which you can also screen them for, offer them a food box. There's resources. Both Adrian and I have dot phrases that offer a lot of different resources there. Try to start buprenorphine in the ED for people who have a COWS of greater than 8, and advocate for your patients' communities. The food box is on hold, I think, due to JCO at the moment. JCO seems to be constantly here. Hopefully they'll stop bothering us at some point.
I think they're just waiting for them to come. Continuing preparation until they actually come.
And I'm sure when they're done with county, they'll be at downstate. It's an infinite thing.